I'm David Kimberlin. I'm a professor of pediatrics at the University of Alabama at Birmingham, where I'm co-director of the Division of Pediatric Infectious Diseases. I also, for the last several decades, have been the principal investigator for the pediatric studies that were conducted by the Collaborative Antiviral Study Group, an NIAID-funded multi-center network that's conducted a number of different studies that I'll review for you here over the next little bit on congenital CMV and the treatment thereof. And now we are continuing, the same consortium is continuing as the Congenital and Perinatal Infections Consortium, which is part of the NCATS RDCRN, which also is in collaboration closely with NIAID. So I'm going to be presenting data on completed studies that were performed by the Collaborative Antiviral Study Group. And then for future studies, we may touch on some of the CPIC studies as well. It's the same group of investigators. And I'm privileged to be able to represent these data on behalf of those investigators because, as we know, this is a rare disease. And if you undertake a study of a treatment of congenital CMV at any one study site, it would take probably 40 years to complete the study. So we need to pool together our resources, both human as well as monetary, to try to make advances in the field. And I think we've contributed some of those advances. So I'm delighted to share that with you today. As we get underway, I want to point out one of the unique aspects of congenital CMV, and that is when a fetus is infected in utero with cytomegalovirus and then subsequently progresses to delivery. When the baby is born, they either have symptomatic congenital CMV disease or they have asymptomatic congenital CMV infection. About 90% of all the pregnancies that are, have involved a congenitally infected fetus, about 90% of them will be asymptomatic at birth, and about 10% will be symptomatic at birth. The babies that are symptomatic are more likely to have the sequelae that we worry about from congenital CMV, specifically sensorineural hearing loss, and then they also will have neurodevelopmental delays as well to a much greater extent than those babies who are asymptomatically infected. But it is the asymptomatic population, because there's so many more of them, 90% of the babies congenitally infected are asymptomatically infected at birth, or they're infected in utero, but they're asymptomatic at birth. Because of that, the overall burden of sensorineural hearing loss is actually larger in the asymptomatic group, even though each individual baby, if asymptomatic, has a much lower risk of sensorineural hearing loss than is the case for symptomatic congenital CMV. So just to lay that out there about the intricacies of symptomatic infection, asymptomatic disease for congenital CMV infection, which is the most common in utero viral infection in the United States. About 1 in 200 babies born in the US will have congenital CMV infection. And again, those about 90% asymptomatic and about 10% symptomatic at birth. This is a photograph from, I think, the 1970s of a baby with symptomatic congenital CMV, and you might be able to appreciate a degree of microcephaly with this particular baby. You certainly see a petechial rash and kind of a ruddy hyperbilirubinemia from the direct hyperbilirubinemia that goes along with symptomatic congenital CMV infections. And if you did an imaging study of this baby's head, what I'm about to show you is not from that particular child, but it very well might look like this. You have these rather pathognomonic periventricular calcifications that are highly suggestive of a congenital CMV infection. And again, this would be a symptomatic congenital CMV infection. This slide demonstrates why we really think about CMV to the extent that we do. It lists out the causes of deafness in the United States. The pie graph on the left-hand side is the causes of deafness at birth, and on the right-hand side is causes of deafness at 4 years of age. Let's focus on the one on the left first, the causes of deafness at birth, and you can see that the red portions of this pie graph are deafness at birth from babies with asymptomatic congenital CMV and symptomatic congenital CMV, and it accounts for about a fifth of the pie. About 20% of all deafness at birth is caused by congenital CMV infection, about half symptomatic and about half asymptomatic. Then you have a number of genomic syndromes, specific mutations, genetic non-syndromes, other environmental causes, filling out the remainder of that pie graph. Now, if you look over at the 4-year pie graph, the proportion of deafness that's attributable by congenital CMV has now grown to be about 25% of all causes of deafness when you get out to these first few years of life. And the proportion of the pie graph has shifted as well. The numbers that are contributed by asymptomatically infected babies with congenital CMV infection, that's a larger slice of the pie than it had been over in the portion of the pie at birth. And the reason for that I'm going to go over in the next few slides, but suffice it to say that just of all the babies that are going to have sensorineural hearing loss, they do not have to have it at birth. It can progress, it can develop over time. And since there's so many more asymptomatically infected babies, that's why this particular portion of the graph becomes larger. And then you can see the remaining causes as well in that remainder part of that particular pie graph. These data on this slide were summarized by Fred Dolly at the end of his career. He was an audiologist here at the University of Alabama at Birmingham and spent decades studying congenital CMV with Rich Whitley and Bob Pass and Bill Britt and Sergio Stagno. And sort of a swan song publication was put out in an Audiologic journal in 2000. And I pull from a table to represent here. And some of these numbers can change a little bit in the literature, but this gives you a very good sense of what the likelihood of sensorineural hearing loss is among babies with symptomatic disease at birth or asymptomatic infection at birth. And so looking at these characteristics, about 40% in this study, this longitudinal long-term follow-up study, about 40% of babies with symptomatic congenital CMV will have sensorineural hearing loss, and about 7.5% of babies with asymptomatic congenital CMV infection will have sensorineural hearing loss. Some of these numbers go up a little bit. This can be up closer to 10% in some studies. The symptomatic can be closer to 60% in some studies, but it gives you that idea of how much more likely it is among the symptomatics as compared with the asymptomatics. And then, as I've already alluded to, the characterization of the hearing loss really is quite varied. It can be unilateral, it can be bilateral, it can be high frequency only. Importantly, it can be delayed in onset, or it can be progressive. It can get worse, it can fluctuate, it can get better completely on its own, which is why it's important to do well-controlled studies, as the Collaborative Antiviral Study Group has conducted. And then some babies not only fluctuate better and worse, they simply improve on their own. So you can look at the proportions here from this particular data set, but I think the main thing that I want to leave you with is this likelihood or possibility of delayed onset hearing loss, progressive hearing loss, improving hearing loss, and fluctuating hearing loss, and the fact that it can be unilateral or it can be bilateral. Now, on the next slide, what I want to do, this is also going to be from the Dolly paper, we're going to drill down into the universe of babies that have sensorineural hearing loss. So what's going to be on the next slide are the 41% of babies in the symptomatic column that have sensorineural hearing loss at some point, and the 7.4% of babies in the asymptomatic column that will have sensorineural hearing loss at some point. And all of those, since I'm drilling only into that universe, what I represent on this slide is the proportion of those babies who are destined to have sensorineural hearing loss. What proportion of them will have it at birth, or at 3 months, or 6 months, or 3 years, or 6 years, on out to adolescence? So all of them on this slide add up to 100%, because that's the population I selected. I selected to represent on this slide those babies that will develop sensorineural hearing loss. And I point this out because about 45% of babies with symptomatic congenital CMV disease who are destined to have sensorineural hearing loss will have hearing loss detectable at birth or within the first couple of weeks of life. That means 55% do not. About 25% of babies with asymptomatic congenital CMV infection who are destined to have sensorineural hearing loss will have hearing abnormalities at birth, but 75% will not. So many people have advocated for what's called targeted screening, where you only look for congenital CMV infections in babies who fail their newborn hearing screen. These data suggest why that is an inadequate approach, because the majority of babies who are going to have CMV-associated hearing loss don't have it at birth. 55% of symptomatics, 75% of asymptomatics will have normal hearing at birth and then will go on to develop hearing loss over time. Now let's talk some about the treatment studies. This is going to be the focus of the remaining portion of this talk. The population that has been studied so far are the babies with symptomatic congenital CMV disease. And isolated sensorineural hearing loss has been counted in these studies as a manifestation of symptomatic congenital CMV disease, but very few babies in our studies had isolated sensorineural hearing loss. They usually had microcephaly or low platelet count or elevated hyperbilirubinemia from direct hyperbiliry, those kinds of things. It's unusual, very unusual, that they have isolated sensorineural hearing loss, although they could. And another very important factor with all of these data that I'm going to show you until we get later, and I'll draw your attention when we deviate from this, all of the studies are designed such that the treatment is started within the first month of life. Now, we started out initially looking at the drugs evaluated and the treatment courses assessed. We started out initially by evaluating intravenous ganciclovir. And there was a phase 2 study I'm not going to show you data from the 1980s that determined what dose of intravenous ganciclovir was tolerated well and would be reliably associated with virologic response. We then took that into the 1990s. These are data from the Collaborative Antiviral Study Group into a phase 3 study that was randomized controlled study with intravenous ganciclovir in half the babies and the other babies randomized to no therapy. We then had a PK/PD study called the CASG 109 study that assessed the oral Valganciclovir dose. The treatment duration there was 6 weeks, as it had been in the treat-no-treat study design. And then the most recent study that we've completed and published is the oral Valganciclovir study of 6 weeks of treatment versus 6 months of treatment. So let's start in with this first group, IV ganciclovir versus no therapy, treatment duration for 6 weeks. This was the CASG 102's trial. It was a phase 3 study, as I mentioned. And what's represented here, I'm going to tell you a little bit about these study designs, or the layout of the slides, I should say, because it's going to be relevant. Ganciclovir recipients are represented on the left-hand side of the slide. No treatment recipients, or the no treatment group, is represented on the right-hand portion of the slide. The pie graph is separated into 2 groups. And what's being looked at here is the change in hearing between birth and 6 months. And this is a total ear representation. So this is comparing, baby X's left ear at birth and left ear at 6 months, and baby Z's right ear at birth and right ear at 6 months. And, you get the idea from there. And it's comparing whether the hearing in that ear has either worsened, or if it starts out abnormal, let's say moderately impaired, it retains that degree of abnormality when it's reassessed at 6 months. And that's the group in red. The other group are those that either had improved hearing between birth and 6 months, the ears that had improved hearing over that period of time, or started out normal. You can't get better than normal, so it maintained normal hearing over that first 6 months. And what I show you on this slide is that the proportion of ears that worsened or maintained their same degree of abnormality was 31% between birth and 6 months for the ganciclovir recipients. They got 6 weeks of ganciclovir therapy intravenously, versus 61% of ears worsening or maintaining the same degree of abnormality in the group getting randomized to no treatment. This was statistically significant, but with pretty wide confidence intervals. Now I'm going to show you from the same study the data comparing the ears between birth and greater than or equal to 1 year of age, and on average it was about 2 years of age. So same group, ganciclovir recipients, 6 weeks starting within the first month of life, 52% of ears worsened or remained the same degree of abnormality between birth and about 2 years, versus 78% of ears in the no treatment group worsening or remaining abnormal to the same extent. Again, statistically significant, with an odds ratio of about 4. Now I'm going to back up a slide and then forward, and I'm going to do it again. You get the sense there's more red as you go farther out from the treatment. It gives a suggestion that perhaps there's some slippage of the audiologic benefit as demonstrated in this study. And so for that reason, we were looking for a way that we could treat longer than 6 weeks, but we couldn't do it with IV Valganciclovir. It's just too harsh a drug. So by this time, this was the very late 1990s, beginning of the 2000s, Valganciclovir was available. And it came in at that point in time, a research use only liquid preparation. And as you know, Valganciclovir is the valine ester prodrug of ganciclovir. It's absorbed from the stomach, and then on first pass metabolism through the liver, it's the little valine is cleaved off, and you're left with ganciclovir in the blood. This CASG 109 study was a PK/PD study, and we determined throughout the course of the study, I'm not going to show you the data here, that a dose of 16 milligram per kilogram per dose of oral Valgan given twice a day gave the same systemic exposure to ganciclovir as did the 6 milligram per kilogram per dose every 12 hours of intravenous ganciclovir. So we then had a dose of oral Valganciclovir that we could take into a study of 6 weeks of therapy, since we'd shown that to be better than no treatment, versus 6 months of therapy. And I'm going to show you now those data. The primary endpoint was change in hearing between birth and 6 months. The reason that we chose that is because that's what we had the most data on for sample size calculations. The 6-week group, treatment group is on the left. The 6-month treatment group is on the right. Same layout, worsened or remained abnormal. And I think the important thing here, 45% of ears worsened or remained abnormal in the shorter term treated group. 37% of ears worsened or remained abnormal in the longer treated group. This was not statistically significant. But when we looked at it 1 year, we did see such a difference. 43% of ears worsened or remained abnormal in the shorter term treated group versus 27% of ears in the longer term treated group, p-value 0.01, and adjusted odds ratio of about 3. That was looking at the ears between birth and 12 months. And then looking between birth and 24 months, 36% of ears in the shorter term treated group worsened versus 23% of ears in the longer term treated group worsened, I should say as well, or remained the same degree of abnormality, still statistically significant with a p-value of 0.04 and an adjusted odds ratio of about 2.6. Now, we also did a Bailey-3 developmental test or assessment on these babies. This is a neurodevelopmental test that has 7 components. And since in a way this was kind of multiple testing because the Bailey-3 is split into these 7 categories, we did a Bonferroni adjustment and required that the p-value be less than 0.0071 to be considered statistically significant. That's 0.05 divided by 7. And what I show in this light blue font are the two the two components of the Baileys that met that degree of statistical significance. With the Bailey score, you want to have a higher number for each of these categories. And at one point I want to make is that every number in the 6-month column is higher, better than the number in the 6-week column. It's these two, though, that reached the threshold following the Bonferroni adjustment. And interestingly, these are language composite and receptive communication scale scores. We did adjust for baseline hearing and follow-up hearing here, and we still saw this degree of difference with better outcomes with the longer-term treated group. Now, we have had a couple of recently completed or recently halted studies, and I want to mention these briefly to you. The Valgan Toddler study was recently completed. I presented these data at the ESPID meeting in the early summer, late spring of this year. It was a phase 2 study, and the important thing here is that what we tried to do was look at whether we could start treatment beyond the first month of life. You know, because I've already mentioned several times that all these studies up until this point were starting treatment in the first month of life. And so the intent was really to identify babies children between 1 month of age up to their 4th birthday who had sensorineural hearing loss that was detected later in life, you know, beyond the neonatal period, in other words. And we really intended to be enrolling the asymptomatically infected babies. I don't think that's the group we ended up with, but that's what we intended. And the primary endpoint, we used 6 weeks of treatment, and the primary endpoint was change in hearing between baseline and 6 months. I'll show you those data in just a moment. The other study that was halted was a study of asymptomatically infected babies, where we had to screen, thousands of babies to identify enough to enroll on the study. They could not have sensorineural hearing loss at baseline. It was going to be a phase 2 study, single-arm study, because we couldn't afford and couldn't get large enough numbers to do a controlled study. But interestingly, after the first 7 subjects enrolled, 3 of them had pretty significant neutropenia, and that study was halted. I do not have any data for that to show today, but I'm happy to answer questions on the panel discussion. So let's look at the Valgan Toddler. Again, this is the group getting where treatment has started beyond the first month of age. A randomization 1-to-1 between Valganciclovir and placebo. You see the spread of ages by year, first year of life, second year of life, and so on, whether they were symptomatic or asymptomatic at birth, and the gender distribution. And look here, look at how many of these were symptomatic at birth. And again, this was not our intent. We did allow for it, and we overpopulated the study inadvertently. I'm not sure if it really mattered, but I do think it might explain our negative results. And you see that about 4/5 of the Valganciclovir randomized group were symptomatic at birth versus about 2/3 in the placebo group. Now let's look at some of the data. You're going to see variations of this slide over the next several, and I'll move through them pretty quickly. But this is the Valganciclovir treated babies in the second column from the left, placebo treated babies in the column immediately to that right, and the total in the far right column. No babies improved. 6 Valgan babies had no change between baseline because they were normal at birth and normal at 6 months versus 9 in the placebo. 14 had abnormal and abnormal, same degree, mild to mild, moderate to moderate, that kind of thing in the Valgan, and 18 in placebo. And if anything, we definitely had more babies that worsened in the Valgan group than we did in the placebo group. And so I'm gonna now just show you the different breakdowns of our analyses. Our primary endpoint was looking at improved or no change, whether normal or abnormal versus worsened, not statistically significantly different. Looking at improved versus everything else, not statistically significant because then nobody improved. Looking at improved plus normal to normal, no statistically significant difference. And then we did a post hoc analysis trying to look at the asymptomatic at birth Valgan and placebo, and the symptomatic at birth Valgan and placebo. These numbers are so small, we did not analyze them statistically, but I think if you just look across the cells, it's underwhelming. I think this is a negative study. And then we also looked at whether they were within the first year of life versus beyond the first year of life up to their 4th birthday. And again, numbers are so small in the cells, we didn't look at them statistically. But, except for the worsening, the Valgan subjects having worsening hearing within the first year of life, which is just a numerical observation, I see this as a very balanced kind of look across these cells. So let's summarize. Antiviral therapy in patients with symptomatic congenital CMV provides modest benefit in hearing outcomes when initiated within the first month of life. Antiviral therapy of patients with a mixture of symptomatic and asymptomatic congenital CMV started beyond a month of life up to 4 years of age is not beneficial. Now, that was in our randomized placebo-controlled trial. I do want to mention that the folks in Belgium and Bossen's group have conducted a non-randomized study called the CONCERT study that did provide benefit. And they did a random intercept type of analysis that it was pretty novel in the way they looked at it. And we're working with Anne's group to do an additional post hoc analysis to see if analyzing our data using this same random intercept type approach might show something different. It's not going to validate our study necessarily, but if we can learn more from these difficult to conduct studies, we want to. And so we've got another call with Anne's group coming up just within the next 2 or 3 weeks. Now, in their study, they were under 3 months of age, and their treatment course was 6 weeks as well. And then finally, treatment of patients with asymptomatic congenital CMV, those without hearing loss, in other words, should not be undertaken with the current antiviral drugs. That was from the asymptomatic study that had 3 of 7 with significant sensorineural hearing loss. Now, I was also tasked to talk about what the guidelines are. There were international consensus guidelines released by Bill Rawlinson. He's an Australian. It included representation from Asia, from Europe, from Australia, obviously from the United States, and I believe from Canada. And these guidelines were published in 2017. And what I have in a red box here is, that's my box put around there. They recommend treating neonates with moderately to severely symptomatic congenital CMV disease, but it has to be started in the first month of life. It's with Valganciclovir given twice a day, and the treatment duration should not exceed 6 months. Likewise, Sue Luck in the United Kingdom led an effort across Europe to come up with guidelines that were published later that year in 2017. Their recommendations are for babies with, significant disease, central nervous system disease, microcephaly, chorioretinitis, central nervous system calcifications. You can read all that. That in those babies, they should get either ganciclovir or valganciclovir. The duration of therapy should be 6 months. And then other severe disease, that's not including CNS disease, again, they do recommend treatment, but they allow for a minimum of 6 weeks of treatment and going up to 6 months. And then for both of these guidance documents, limit their treatment recommendations to moderately to severely affected babies. So with that, I'm going to stop. I look very forward to the panel discussion that will follow. I appreciate your time and your attention, and for your interest and consideration of these babies with symptomatic congenital CMV disease. Thank you very much.